Thank you for the introductions. Yes, that's my name, Alice Mulema. So I'm going to present a case of twin-to-twin transfusion syndrome. And we decided to, so we are going to present a case of twin-to-twin transfusion syndrome, but what we should take note is all the complications that Dr. Ndagurwa was mentioning, they are not mutually exclusive. They can all happen at the same time. And this is one of the cases that you can see all the complications occurring at the same time. So she has already given us the definition of twin-to-twin transfusion, where we have got unidirectional placental vascular anastomosis. So one twin is the donor twin and the other one is the recipient. And this imbalance is going to cause cardiovascular strain, amniotic fluid discrepancies. And like we have already learned, it affects 10 to 15% of monochorionic diamniotic twins. In Zimbabwe, from the numbers in our fetal medicine unit, we have recorded an incidence of about 8%. This is lower than the global numbers because, like we have already learned, twin-to-twin transfusion syndrome has a mortality rate of up to 80% when it's not managed. So we do not tend to see these babies a lot because they demise before they are even referred. And I think this meeting and this case really falls in the theme of this meeting, which says strengthening standardized fetal medicine referral and management pathways. So if we refer them, if we strengthen these referral pathways, it means we have these twins managed earlier. So our case is of Mrs. VM, aged 21 years old, in her first pregnancy with no previous miscarriages. She was booked at 21 weeks. Like Dr. Werenga has said, most book later on after the first trimester. Her first trimester, according to her, was uneventful, but she started feeling this abdominal discomfort around 20 weeks. And it was worsening, associated with dyspnea. So she decided to book a pregnancy, and an ultrasound scan was ordered. Ultrasound scan showed a discrepancy in the amniotic fluid volume, and it also showed discrepancies in, so the first ultrasound showed that discrepancy in amniotic fluid, and she was referred to Salim Mugabe Hospital. At Salim Mugabe, in the multiples specialist clinic, she was seen, and the discrepancy of amniotic fluid was confirmed, as well as a discrepancy in the estimated fetal weight. Investigations were done, including an infection screen, oral glucose tolerance test, and the patient was normotensive, and there was no history of draining when we took the history. So at this point, with the findings of discrepancies in amniotic fluid volume, discrepancies in fetal weight, were differential diagnosis, TTS, selective fetal growth restriction, which could also give that discrepancy in fetal weight, but it does not give the discrepancy in amniotic fluid. So this diagnosis did not really fall into place. This could be caused by upper GI abnormalities like duodenal atresia, and this way scanned for in both the twins, because when a twin is affected with the upper GI abnormalities, then they are going to have the polycythemia. But in this case, the recipient twin did not have these atresias. The donor twin could actually have renal abnormalities like renal agenesis and could give the picture of the oligohydramnios, but this was scanned for and the twin did not have that. Another differential was TEPS, and we did the middle cerebral artery Dopplers, which I am going to share. Another would be TREPS, but in this case, they were both viable twins. So I'm going to share the images, but the first images were really limited because the patient had excessive dyspnea and discomfort, but we managed to make the diagnosis and to rule out the abnormalities that I have spoken about. I would need help with the cursor. So for the first picture, which is on my right, it is showing oligohydramnios in the recipient twin, which was about 18.2 centimeters, thank you. Then the next diagram, it is showing the fetal bladder of the recipient twin. I do not have pictures of the amniotic fluid in the donor twin because the pool was not measurable and the bladder was not visualized. These were actively looked for because they've got a bearing on the staging of twin-to-twin transfusion syndrome. So Doppler studies, umbilical artery Dopplers were done for the recipient twin and for the donor twin, and they were both normal. Middle cerebral artery Dopplers, so there was a discrepancy. For fetus A was the donor twin, there was a high PSV of about 59, and when we used the calculator to calculate the multiples of median, it was about 2.07. Then for the recipient twin, it was about 34. So this shows us that there was anemia in the donor twin and polycythemia in the recipient twin. And this table is showing the Quintero staging that Dr. Ndagura was talking about. And according to this staging system, our patient was stage 2. Because we could not visualize the fetal bladder in the donor twin, we already had the oligohydramnios and the polyhydramnios, and we could not visualize the fetal bladder in the donor twin. But our umbilical Dopplers were normal. So this was stage 2. And then we planned for the management of this patient. Like she has already said, that the management that we are looking at, will take care of the pathophysiology is the fetoscopic laser ablation, but we do not have it in the country at the moment, and work is being done to have it. So what we're going to do was conservative management. And for stage 1 of TTS, there is always a management dilemma, trying to balance expectant management and early intervention. So a study was done by the North American Fetal Therapy to compare expectant management, laser therapy, and serial aminoreduction. And during this study noted that if we manage patients with TTS expectantly, 22% may actually regress, 8% may remain stable, but 60% can advance in stage, and 10% can have pre-viable preterm deliveries. So patients who had intervention had a lower risk of fetal loss in this study. Our patient was stage 2, and our management options, we have said we do not have the fetoscopic laser coagulation, so our options were aminoreduction, septostomy, or selective feticide, but this can only be done in the pre-viable stage. So we considered aminoreduction. Aminoreduction helps to prolong the pregnancy because you've got this woman, like I said, she was already dyspneic, and she had polyhydramnios, which could predispose to preterm labor. So when that amniotic fluid is reduced, you prolong the pregnancy and allow the babies to develop. Again, when we reduce the amniotic fluid, it means we are allowing this uteroplacental unit to be better perfused and be able to sustain the pregnancy or sustain these babies. So again, I'm going to share with you like this table, which was comparing serial aminoreduction, septostomy, and fetoscopic laser coagulation. In terms of survival of one twin or survival of both twins, survival of one twin, when we compare what we are going to do for our patients, which is aminoreduction and fetoscopic laser coagulation, survival of one twin is comparable for those management modalities. The difference comes really in neurological deficits. Dr. Ndagura told us about selective intrauterine fetal demise. So in TTS, you can have selective intrauterine fetal demise, and when that happens, the survival twin will suffer neurological deficits. So when we use laser for coagulation or for management, we reduce the risk of neurological deficits. We're going to do aminoreduction, which still carries a risk of 30% in the event that we lose one of the twins, which is one of the complications of aminoreduction. And for septostomy, it means we are putting an incision between the membrane separating the twins to allow the fluid from the one with polyhydramnios to the one with oligohydramnios. It carries a risk of cord entrapment whilst the fluid is moving, and again, it also predisposes to preterm delivery. So this diagram is showing us the procedure which was done by our specialist on amino reduction. You can see the needle going in and removing the amniotic fluid. So our patient had two series of amino reduction. On the first one, she was admitted, counseling was done. On this time, like she was going to have this procedure for the first time, so she had a series of counseling telling her that this may predispose to preterm labor. And again, the condition itself, she has to be told that she could actually lose her babies. So the amino reduction was done, and the patient was observed for preterm labor. Cervical length was measured, and it was reassuring. We reviewed our patients 19 days post this procedure, and clinically she had no abdominal discomfort, no dyspnea compared with the first time we saw her. From then on, we continued the weekly reviews, monitoring the Dopplers, and the fetal growth was monitored 2 weekly. Then a second procedure was done to reduce the amniotic fluid in the fetus. So this diagram is showing you, the first one is showing us the difference in amniotic fluid on day 19 post the first amino reduction. We can actually see that initially we did not have any measurable pool of amniotic fluid, but on this time, still there were membranes covering the baby. It was better from the stuck phenomenon which we saw initially, but then the decision was made to repeat this so that we can free the baby. The second picture is showing us after the second amino reduction. And in this picture, the baby were more free. The baby had more amniotic fluid around them, and this was reassuring that like growth was happening unlike the first time. Sorry. So this picture is just showing us, it's a graph showing us the estimated fetal weights of the baby. So the first time we saw them, there was a discrepancy. And the donor twin was about 600 grams and the other one was 1,000 grams. And like we have already learned about the charts, so our donor twin continues to grow, although right on the line, like on the 10th centile, whilst our recipient is growing at a higher rate than the one, but we'll continue to monitor them and also continue to monitor the middle cerebral artery Dopplers for the twin anemia polycythemia sequence. So in conclusion, I presented a case of twin-to-twin transfusion syndrome with selective fetal growth restriction in the donor twin and twin anemia polycythemia sequence, which was diagnosed at 20 weeks of gestation and managed by amino reduction. Maternal symptoms improved and the amniotic fluid discrepancies reduced. Although fetoscopic laser is the first line of management, amino reduction can help reduce the risk of preterm delivery and neurological deficits in the twins, and it is important to refer monochorionic diamniotic twins to specialist units on time. Thank you.